Hi everyone, welcome to the 2020-21 Hume Annual Forum. My name's Michael Kalimnios. I'm your MC for today. I'm the chair of the Hume Governance Committee, and I'm also the Chief Executive Officer for Albury Wodonga Health. I'd like to start by just acknowledging the traditional owners of the various lands on which we're meeting today, right across Victoria and New South Wales. And of course, pay my respects to elders past, present and emerging. I extend that respect, of course, to Aboriginal and Torres Strait Islander peoples here today. So welcome. We've got quite an interesting agenda to run through today with a number of speakers, which hopefully you'll find very informative and interesting. Without further ado, I'll hand over to the first of those speakers. And our first speaker is Craig Underhill. Many of you would, of course, know Craig. He's a senior medical oncology consultant. He's also a director of Albury Wodonga Regional Cancer Centre. He's one of our divisional directors at Albury Wodonga Health, and of course has had a fantastic record in promoting oncology services and the establishment of regional oncology services, not just here in Albury Wodonga, but certainly for the Ovens-Murray area and indeed for the whole of the Hume. Craig will be talking to us today on the use of telehealth for patient care. So, as I say, without further ado, I'll hand over to Craig. Craig.
Thanks very much, Michael, for that introduction. I'm just going to share my screen. Hopefully you can all see that. Anyone of the hosts want to give me a thumbs up that you can see that?
Yes, thanks, Craig.
Terrific. All right, so this is the title of my talk, the use of telehealth to support patient care before and during the pandemic. Thanks very much to the organisers for asking me to present on this. These are the topics I'm going to cover tonight: the uptake of telehealth during the pandemic and using it in patient consultations and MDT meetings, the Hume Upper GI Cancer Project, using telehealth to collaborate, teletrials, or what the Americans are calling a digital clinical trials or decentralised clinical trials, and a project that we're involved with across regional Victoria using telehealth to do health services research. Before the pandemic, it really felt like we were dipping our toe in the water of telehealth. We did occasional telehealth consultations, often the patient sitting with a GP in a remote centre. But with that outbreak of the novel coronavirus, suddenly telehealth was a necessity, and with support from the Australian government, there was a number of telehealth item numbers which helped drive a switch over to telehealth. This is the Hollywood view of a telehealth consultation with the patient reclining, not sure why she's wearing a mask if she's on a telehealth call, but reclining on a sofa with the doctor talking to her on a iPad. But the reality was unfortunately something a little different, as the sudden need to do multiple telehealth consultations in a day, and the need to set up some systems to help support the patients and administrative staff in the processes around telehealth, which are quite complicated or can be complicated. During the pandemic, one of the good outcomes was a real sense of collaboration. And in Victoria, there was a network set up called the Victorian COVID-19 Cancer Network, or the VCCN. And there was a directors group, and Javier Torres and I sat on that, and it published this paper towards new models of cancer care in Australia, lessons from Victoria's response to the COVID-19 pandemic. So there are a number of different new models of care considered during the pandemic, but one of the strong elements was the use of telehealth in routine cancer care. There was also a telehealth experts reference group, and they published this paper called Telehealth in Cancer Care During and Beyond the COVID-19 Pandemic. So this was intended to be a practical guide and includes a comparison of different telehealth platforms and discusses principles of telehealth. One of the barriers to telehealth is the need to examine the patient. This paper talks about a model where you can utilise the GP in a remote town to help in that process. It comes down to a number of tumour level recommendations on the appropriate use of telehealth for cancer consultations. So are telehealth consultations acceptable to patients? This was a paper recently published from a group out of Sydney. Andrew Parsonen is a fellow in medical oncology at Nepean Hospital, and he led this cross-sectional study of 150 cancer patients were approached, 103 replied, 63% of those people had advanced cancer and 81% were on active treatment. And you can see that overwhelmingly in the question 1, 2 there, that patients strongly had a preference that video or telephone consultations were satisfactory. If you come down to question 9 and 10, there was a bit more of a split in the feeling towards whether it was important for the specialist to examine the patient and would they rather travel to hospital. But interestingly, what was associated with wanting to continue telehealth consultations subsequently was the use of phone versus video, whether the person had advanced cancer versus early cancer, and whether it was a pre-treatment consultation or a follow-up visit. So they preferred to do follow-up visits by face-to-face. So I found the preference towards phone consultations over video a little bit counterintuitive, but nevertheless, that tells us that we do need to ask patients what their preference may be. It does feel like telehealth is here to stay. Hopefully those NBS item numbers will continue. In June, there was 3.4 million consultations done by telehealth, but interestingly, 93% of those were by telephone and 7% were via video conference. Just speaking a little bit about the Albury-Wodonga Health experience in the multidisciplinary team meetings. Before the pandemic, we had a number of hybrid systems. Most participants were present face-to-face. We did have some metropolitan clinicians dialing into lung and gastrointestinal tumour meetings. If a participant was unable to be present at the face-to-face meeting, they were able to dial in, but often that was with a speakerphone in the middle of the room, which was not that satisfactory in terms of sound quality. And regional clinicians were again able to dial in by telephone to some metropolitan meetings. But with the pandemic and meeting restrictions, that rapidly triggered a conversion to fully online meetings. So our meetings started to look like any standard Zoom meeting. And the question is, will we go back? February this year, the Humerix team did a brief polling of the participants, and the majority preferred the online meetings, especially the radiologists and pathologists who need to be present at multiple meetings during the week. And it was much easier for them to present the information from their computer setups at home rather than coming to a room, setting up a laptop and then presenting from there. People preferred the technical quality and especially the sound issues compared to the hybrid meetings. Comments were that it was more ordered and there was more clear summation, and it was convenient. You could just dial into a computer from anywhere, do the meeting and then go about your business rather than having to drive and park, go into the meeting and then go somewhere else afterwards. But they did miss that face-to-face interaction. Humerix have run a project using telehealth to collaborate. So we wanted to improve outcomes for patients with upper GI cancers and establish better communication between metro and regional health services. So we have patients going down to Peter MacCallum or Royal Melbourne for complex surgery in upper GI cancers, but they're already discussed in our virtual MDT meeting. And so we wanted to look at some technological telehealth solutions for better communication. And we've piloted using this system called REDCap, which was actually created, it's an open source free application, was created by the Vanderbilt University in 2004 by a group of researchers wanting to look at a secure data collection tool that met the relevant compliance standards, and this REDCap or research electronic data capture is what was come up with. So we've utilised that to put patients onto the system. It automatically generates an email notification when someone is added to the system, and clinicians at both services, and not just the doctors, but more particularly the care coordinators, allied health staff, can share information, data is collected, there's reduced duplication of data entry. And I think there's definitely a mentoring role between the various staff members across the institutions. And this is some of the information clinicians report. It's an effective tool for communication in the absence of a shared electronic health record, and it aligns with the Victorian Cancer Plan's aim to improve communication and collaboration to ensure quality care is provided to regional patients. So, so to date, people have been happy with this system in the absence of a proper shared EMR. In the remaining time, I just wanted to change tack to talk about teletrials. So this is using telehealth to run clinical trials. So again, there's been a big uptake in that during the pandemic. In the US, they talk about digital clinical trials, so using digital health to run a trial. And in Canada, they've utilised the term decentralised clinical trials. And the Regional Trials Network Victoria and the VCCC teletrials program is an example of the acceleration in the use of teletrials during the pandemic. So in 2017, there was about 1,500 patients in Victoria enrolled onto a cancer clinical trial. 27% of those were regional residents, but only 81 of those people were enrolled in a trial in their region. So the other 320 travelled to Melbourne. The Regional Trials Network was created as a project by the Victorian Cancer Agency and the Cancer Council of Victoria, and it's 6 regional sites listed here. So Shepparton and Albury-Wodonga are 2 of the sites, and Cancer Trials Australia was our metropolitan partner. At the same time, the Victorian Comprehensive Cancer Centre, now the VCCC Alliance, developed a teletrials program, again with the aim of improving trials access and participation for patients living in regional and rural locations using a telehealth model. So COSA, which is our peak national organisation, published this Australasian teletrials model. So it's using telehealth to run a clinical trial. The idea is to have a cluster between primary site and satellite sites, and each of the sites has a different role specified upfront for the conduct of the study. So running a trial by telehealth is not a lot different to doing a clinical trial. And we've all become comfortable during the pandemic of doing things by telehealth. We have meetings by telehealth now instead of people from the sponsors coming to the site to run meetings. They're able to monitor data remotely rather than coming on site to look at patients' notes. Various documents can be shared online through portals, etc. So we've come a long way in implementing this teletrials model. The VCCC teletrials program at the time of the project opened 6 trials, and many have since started up. The first teletrial called Target TP recruited more than 150 regional patients. The VCCC assisted the Alfred in the rapid startup of a phase 1. So there was a patient in Hobart who was flying to Melbourne to access a phase 1 study, a new drug. And during the pandemic, that was converted to a teletrial. Patient stayed in Hobart did telehealth consultations, and the drug was shipped to Hobart to be dispensed. And now multiple models have been tested in this teletrial space. It's been vigorously evaluated. IQVIA, which is a contract research organisation, has done 2 audits of the first teletrial. There's a consumer perspectives qualitative study. There's some online education modules and toolkits available. There's been a publication in the MJA describing the implementation of the telehealth, and also a health economic evaluation, which has shown considerable cost savings to the system, and that's been submitted for publication. So the benefit for using the teletrial model, I think, is not just in improving recruitment to trials and improving access, but there's a real sense of collaboration and networking between regional and metropolitan sites. It helps develop capability of the workforce, and I think there's great opportunities in the rare cancer space. So this is a graph showing improved recruitment to trials during the project time of the Regional Trials Network Victoria. But overall, we went from that 80 patients to a substantial increase in the number of patients recruited to clinical trials. And a lot of that was driven by the teletrials uptake. COSA have also recently published a report documenting the experience right across Australia. So where to next in the telehealth and teletrial space? The Regional Trials Network it's in its second iteration. There's some recurrent funding from the Victorian government. They've added Mildura and Latrobe in Mildura, Latrobe in the Latrobe Valley as sites. It represents close to 2 million residents of regional Victoria and close to 10,000 new diagnoses of cancer per year. And this group, the Regional Trials Network Victoria, was able to then leverage some funding from the Medical Research Future funding for $18.5 million over 5 years for the 8 sites to do some using telehealth to enable health services research. So as well as increasing the number of sites, you can see here there's a number of elements of the Revitalise program with some research of particular interest to regional patients. So palliative care and supportive care trials, registry and immunotherapy trials. We're tackling the clinical trials component of the optimal care pathway in Aboriginal and Torres Strait Islander people with cancer, building capacity and capability in geriatric oncology research, and creating a regional research teaching hub to try and improve research literacy in regional workforce, not just in medical, but in nursing, allied health and junior medical staff. So quite an ambitious program rolling out over the next 5 years, with the ultimate aim to try and bridge that metro regional trials gap by 2025. There's a number of other programs coming into play. The Australian Teletrials program, led by Queensland, was funded with $75 million over 5 years. And they're going to roll out a number of elements, including coordination nationally, trying to improve and streamline the governance process for trials. They have some seed funding to go into sites as well. So we have the Alfred Trials Hub as well. It's RTN Revitalise VCCC program and the National Teletrials program. There's been a series of meetings in the last couple of months, and there's another one next week. We're trying to coordinate the work together so that we don't duplicate and that we can harness this sort of once in a generation opportunity to really try and embed trials across regional Victoria using telehealth. So it's hard to predict the future. This could be a photo of me presenting at the Hume Forum in 2026 using facial enhancement technology during my presentation, or not, but it does seem that telehealth and teletrials are here and now, and they'll be a major tool to enable better access to clinical trials for all patients. So I think one of the benefits of the pandemic has been this uptake of digital health in the cancer sector. Our state and our region, indeed, has been at the forefront of the uptake of telehealth and teletrials. The model works, it's COVID safe, it's acceptable to stakeholders, it's cost effective, and it underpins network formation, mentoring, and upskilling. So just finish by thanking the funders of the Regional Trials Network, to Victorian Cancer Agency, the Victorian Government and Cancer Council Victoria, and to all the collaborators from the VCCC Alliance who contributed to the teletrials program, and finally to the patients and their families who were recruited to the trials in this process. So thanks very much.
Thanks, Craig, and thanks for that presentation. I should have mentioned at the beginning that if people have questions or anything they'd like to raise with Craig or any of their other speakers, if you could please use the Q&A box that you'll have on your screen, and just type your questions in there. We will be having a panel at the end of the presentations that hopefully will be able to answer the questions as they come through the various presentations we have today. Please don't use the chat box. If you can, use the Q&A button, which we'd really appreciate that. Thanks, Craig. Our next presentation is a video that has been put together by a number of people, and it gives an overview of the patient and staff experience of cancer care during the COVID pandemic. And obviously, Craig talked about some of that from a telehealth point of view. So it does include everything from telehealth appointments, care delivery, and staff experience of working from home, including remote learning. Just a quick thank you to everybody, the patients and staff from across the region involved in the making of the video. And just to name some of the key contributors, Tom Watson, who's a patient, Ben Engel, our manager of the Wellness Centre at the Regional Cancer Centre in Albury, Wodonga, Angie Lancaster, who's a cancer survivor, Kelly Scurry, an oncology nurse from Kyabram District Health, Di Roberts, the nurse unit manager from Kyabram District Health as well, Ray McAllis, a cancer survivor with North East Health, Wangaratta and oncology, nurse Cindy Bryan. So thank you to all those people for their contribution to the video. And the video itself is called Together, Overcoming the Challenges of COVID-19. So we might hand over to the playing of the video. Thanks very much.
Probably the biggest one is keeping my wife calm. Somebody sort of to accompany to the specialist appointment, that she hasn't been able to do a lot of that. We had a little bit of a problem early on where one of the nurses said, because she hadn't seen the doctor, the specialist, said, come in on this treatment day and we'll make an exception and we'll let her come through so she can see the doctor. Well, she came in and then the head nurse there said, no, you can't come in.
So I think one of the biggest challenges has just been the general level of uncertainty. And so with the going in and out of lockdowns, that's meant the wellness centre has either been open or closed at different times. It's had a big impact in terms of we've been able to have volunteers at some points and then not able to at other points.
The stress of if you had to go for an appointment in Melbourne where they were in lockdown and, you know, sort of the coming and going from there and making sure that you didn't stop on the way just all, and it adds just another layer of stress over everything.
We have this wave of panic with our patients who, you know, last time we were running a clinic, we had a really full clinic, we had it all prepped, ready to go for the oncologist to come over and do it in person. And with them, we were locked down and, you know, and Shepparton was heavily involved. So I had to call everybody and change it to telehealth, and which is quite a smooth process now. One of the things we did as a health service when it was safe to do so was bring them back into our health service and do a nurse facilitated telehealth session so that the nurse could support them with their access to telehealth, but also advocate for them and answer questions. It's sometimes difficult for patients and their family members to be on the television, not have access to an assessment or clinical sort of touch from that medical oncologist. It's very much a team effort. We all keep each other afloat, you know, and our job here is to provide as seamless a range of care to our patients as we can.
In reference to the myeloma, there is a pilot program at the moment for with Myeloma Australia for rural link nurses to be having sort of specialists and giving us training and connecting us with other myeloma specialists, and we do all that via telehealth.
So we've seen a greater shift to delivery of things online. We get great levels of participation in our exercise oncology program, which has been running online. Same for yoga and also for the mindfulness program.
I certainly don't count myself as a computer literate person. I do the basics on it, and I thought, oh, how on earth would I ever be able to do this? And I don't even have a camera on the computer screen, but I've got a tablet and it's got a camera on it. And, yeah, it's never been an issue. Just follow the steps. So they send the instructions of what to do, and
Great mates now, aren't we? We would never have known each other at all.
Yeah. The girls being able to set it up for us and come and have our appointments at Oncology in Kyabram, we, you know, that just takes just that extra stress off having that appointment, as well as having to worry about the technology. Like the oncology nurses here in Kyabram, they can ring them at any time and they're always available for us, which is really reassuring.
Nothing seems to be too much trouble. As an example, there was one time I needed an extra script because there was some muck up with some tablets that I had, and the script had to come over from Shepparton. My treatment had finished, the script hadn't arrived, and Sarah, the part-time nurse, said, "You go home, I'll drop the script into the chemist for you and you can pick it up in the morning." She didn't have to do that.
I think as health professionals, we think of everybody, not just like our own families, but, you know, I worry for my patients and how they're feeling. And for me, it has been a roller coaster and continues to be a roller coaster. It's very up and down, and that affects not only the hospital response, but how the staff are managing and how we deal with our patients and how we continue to support them and reassure them during this time. It's an ongoing thing, and it affects all our families and all of us personally, but you've got to put your game face on and get on with it and provide good care and safe care, you know, as best we can.
Yeah, I've got to tick this box. Hang on. Yep. That's it.
Thanks for that, and thanks for the video, and obviously a really good overview of the challenges both patients and staff have experienced during COVID-19, which has been challenging for all, but it's really good to see that from a frontline and patient perspective. So again, thank you to everyone who contributed to that. We're now moving to another presentation, and this is for our grant recipients. So there's two video presentations that we'll be speaking to in the video. So the first one is a project called Enhancing Cancer Service Delivery and the Cancer Patient Experience of Care in the Beechworth locality, and that has been coordinated by Liz Ibram from Beechworth Health Services, and you can see there on the screen. Liz is project coordinator for Indigo 4M Models of Care at the Beechworth Health Service. And the second project is improving emergency laryngectomy management for patients attending a regional Victorian health service, a speech pathology driven initiative. And Katrina Rogash from GB Health, who of course is a speech pathologist there, has been leading that project. So thank you to both of them. And again, we'll move to the video. So thanks for that.
In 2020, Hume provided funding for projects to improve cancer patient experience and outcomes. Beechworth Health Service was a recipient of this funding to enhance cancer services delivery and the cancer patient experience of care in the Beechworth locality. Tonight, we have invited Liz Ibram from Beechworth Health Service, who led the project to unify local resources to upskill for supportive cancer care and service coordination. Thanks, Liz, for joining us tonight.
Hi, my name's Liz. I'm the project lead for Beechworth Health Service. Several months ago, I was approached to do some project work regarding enhancement of cancer services for our rural health service. It was a small project and it only took a couple of months, but in that time we were able to tighten up some communication pathways between our health service, our regional health services. So Beechworth Health Service is a small rural health service that doesn't deliver chemotherapy per se, but we are capable of providing adjunct therapies such as transfusions and management of side effects. The project was based at aligning communication between the GP service, our pharmacy service and ourselves. The goal of our project was to enable patients in this region to seek treatment locally for those adjunct therapies rather than to head across to the Border Cancer Centre, hence saving their trip. And you know, if a patient is unwell and actually spends a lot of time at the Border Cancer Centre already getting the chemotherapy treatment, so it saves them time to having to keep going back there for treatments that could be easily sorted in their local area. Their family, less travelling for their family, and just, you know, to receive a service in your local hometown, I think it's very important. I think especially when you're unwell. And also there's a lot of activity at the Border Cancer Centre. It's a very busy centre and it sees a lot of patients. So if we can also relieve some of the flow and the burden off the cancer centre by managing our own, I think it's a twofold bonus. In able to do that, we established a charter of commitment of care to cancer services. So that involved creating partnerships with the GP service, and we were able to get a GP lead. So she was very keen and to establish pathways with the medical services at the Border Cancer Council, and she was also looking at some maybe developing some shared care plans. And we also introduced her to the optimal care pathways, which was used sporadically and not a well-known resource. They did have other resources, but she was very keen to integrate the optimal care pathways into the GP practice. So they were all practicing from the same body of evidence, and we were also integrating, making sure that our policies and procedures, especially with our advanced care planning and palliative care service, had actually aligned with those optimal care pathways as well. So also a review of the back end of our policies regarding palliative care. And I think it's important that the GPs, while they are always using evidence-based practice, to use the gold standard of the optimal care pathways, which are very thorough and I think an excellent resource and should be used throughout all services. So I was very happy that they've taken that on board and run with them. Yeah, that Beechworth was increasing their services, their capabilities, especially more specifically with regards to the management of border cats, which we don't historically manage. So we had to begin some training programs here at Beechworth Health Service to enable our staff to be proficient and competent using border cats and safely and professionally. So that involved developing making sure our protocols and our guidelines and our policies were all up to date, which we achieved. The competencies for our registered nurses were able to be accessed, and that we had some simulation training, which is actually in progress at the moment. The registered nurses were quite happy to upskill in Portacas, for knowing that it was for their community that they service. And Beechworth Health was very eager to keep broadening their services to meet the continuing needs of the community, because the cancer rates of cancer are spread throughout the whole of Australia, and Beechworth's not immune to having a lot of clients in the community. So for the GP service to manage patients with Portacats or with side effects of their chemotherapy, they would now know that Beechworth Health Service were proficient in Portacats and that they could safely send their patients to Beechworth Health Service for their treatments and transfusions. And also the pharmacy, being a small rural town, the pharmacy and the GP and the hospital are quite connected. So if a patient was to wander into the pharmacy and saying, I'm having a bit of trouble with my Portacat, or I'm having a few troubles with my side effects, then the pharmacy, knowing that Beechworth Health Services has now skilled up and able to provide a more broader service for people with CVAD devices. But a lot of policy review and communication. We also approached the palliative care service in Wodonga to share their pathways and their care plans with our district nursing service in Beechworth. So also sharing care plans electronically between the two services. And obviously Wodonga palliative care comes to Beechworth, but not necessarily in the same loop as the district nursing service. So tightened up those pathways and care plans there. Also, the GPs were very keen to have palliative care come to the GP clinic. So we set up those communication pathways as well. So the project is finished now, obviously, and it did go for a short period of time. So I've left it in the hands of the GP to follow up those shared communication medical care plans with the Border Cancer Centre, and also the SIM training is in progress for Portacats.
Hi, my name is Katrina Rogash. I am a speech pathologist at Goulburn Valley Health in Shepparton. I work with adults on the acute and rehabilitation wards. I'd like to thank the Hume Regional Integrated Cancer Service for the opportunity to present on this quality initiative, and for the viewers for their attention. So the project at which I'm going to be speaking about today is titled Improving Emergency Laryngectomy Management for Patients Attending a Regional Victorian Health Service. I'd like to acknowledge all those who contributed over the course of the project. Again, special mention to the Hume Regional Integrated Cancer Service, who provided an improvement grant to us in 2020 that saw this project to fruition. to Amanda Jean White and Emma McDonald, co-authors, and who provided their expertise to me as project lead. So firstly, what is a larynx? A larynx is our voice box. It's the part that sits at the front of the neck and is made up of various ligaments, muscles and cartilage, as depicted in the diagram. And they move to allow air into our lungs when we breathe, to make sounds for voice, for speech, and to protect our airway and lungs during swallowing. So laryngeal cancer is the most common cancer type of all head and neck cancers. It is also the 56th most common tumour, and accounting for approximately 160,000 cases per year worldwide. A total laryngectomy is a surgical procedure used in the advanced stages of laryngeal cancer, which is the removal of all the structures of the larynx, and then the windpipe or our trachea is sewn to the front of the neck, and a hole is made called the stoma that allows the person to breathe. So this is just a nice image depicting the anatomical changes after a total laryngectomy. The key take-home message here is that after a total laryngectomy, the image on the right, the food pipe and the windpipe are no longer connected. The person cannot receive any air through their mouth or nose. They can only receive air through the stoma in the neck. This is why laryngectomy patients are often referred to as neck breathers. Total laryngectomies have a major impact on a person's life. It changes the way they speak, breathe, look, and occasionally swallowing. However, with adequate training and social supports, these issues can be well managed and the person can live a relatively typical life. So once the stoma is created, artificial devices can be inserted into the stoma for different purposes, such as a heat and moisture exchanger or button. So the HME, as it's called, helps reduce mucus buildup and coughing by humidifying and filtering the air which the person breathes through the stoma. Additionally, to create voice, given the vocal folds have been removed, voice prosthesis is inserted through the stoma into a hole called the tracheoesophageal puncture between the windpipe and the food pipe, and this vibrates to make voice. And the image on the bottom right is just an example of someone receiving stoma care where the mucus has built up inside the trachea. These devices may become blocked, displaced, or leak, leading to significant and potentially life-threatening harm such as respiratory distress. So what led to the project? So total laryngectomies are generally performed at specialist metropolitan hospitals, and regional laryngectomy patients continue to receive the majority of their care by that service, such as medical reviews, yearly changes of their voice prosthesis and allied health, and so on. So typically, in relation to GB Health, laryngectomies are a rare and complex patient demographic, with the majority of medical and nursing staff having limited to no previous experience treating these patients. At the time of the project, there were 3 laryngectomy patients living in the Goulburn Valley region. Historically, they would present here to GB Health in the emergency department for emergency airway distress and require timely, effective, and coordinated care. The laryngectomy emergencies were commonly managed by relying on individually acquired skills or lessons learned from previous errors. How relying on this method isn't sustainable and led to suboptimal medical management with potentially life-threatening consequences. Also at GB Health, we do not have a ear, nose and throat physician that specialises in laryngectomies based on campus. It is outsourced from Melbourne on a monthly basis, so getting that specialist medical support is limited and incurred extra cost to the hospital to transfer these patients to their metropolitan service for the specialist care they require. So despite previous speech pathology endeavours to upskill and educate the emergency department, urgent support was needed to better manage laryngectomies in these events. So as mentioned, our overall aim was to improve laryngectomy management within the GV Health Emergency Department. This was completed over a 3-month time frame, so a day per week. So a desktop review and benchmarking was completed with 10 Victorian metropolitan and 4 regional services in regards to their clinical practice guidelines and hospital-related processes. It was identified that the Austin Hospital CPG was appropriate for adaptation to meet GV Health's requirements, and approval was sought and obtained from Austin Health Speech Pathology Department. Survey of knowledge and confidence and skills levels of the GV Health ED staff in laryngectomy care was completed. It consisted of 6 questions relating to various components of laryngectomy management, from identifying a laryngectomy from a tracheostomy, providing stoma care, and events relating to emergency airway management. It was distributed over an 8-week period over AM and PM shifts to ED, nursing, and medical staff. The results really confirmed that there was significant variability in confidence and knowledge levels of these staff that would be providing care to these patients. Overall, knowledge gaps were identified, and this would be addressed during the course of the project. This led to the development of a localised and comprehensive laryngectomy clinical practice guideline. To address the knowledge gaps identified during the survey, the CPG comprised of video links, step-by-step instructions for various components of laryngectomy care, such as inserting catheters into the tracheoesophageal puncture site, stoma care, and so on, and other resources that would be applicable to nursing and medical staff. It also consisted of care across the inpatient stay in GV Health, from the emergency admission to the ward and to being discharged. The document was reviewed by various GV Health stakeholders, from allied health and medical, nursing, across the continuum of care, and to ensure it reflected current best practice and our processes here at GV Health. And collectively, the changes were made, and the CPG was released onto our hospital document management portal, which is accessible by all GV Health staff. The project led to the establishment of the medical alert. So this went through several committees and worked closely with Health Information Services and the IT department in its approval. The alerts can be added to any patient's file, and from this, an auto-generated flag is displayed on the patient's information platforms that can be seen by any GV Health staff, and it flashes the title laryngectomy neck breather to act as a alert that they have an altered airway. And the speech pathology department added this to all pre-existing known community laryngectomies in the region. Once the alert has been added to the patient's file, an auto-generated page to the acute speech pathology department is triggered anytime that patient presents to ED or is transferred into the hospital from another organisation. The speech pathology input is not always required in relation to all situations, such as respiratory distress. However, as speech pathologists have specialist knowledge in laryngectomies and can support locating and utilising the CPG, aiding in voice prosthesis changes and other events as that. So limitations to the project were low response rate to the survey. So the coronavirus pandemic meant that contributing members had conflicting and changing priorities, which decelerated the speed at which inputs were given. And as previously mentioned, we do not have regular ENT support that could guide medical management, ensure that the CPG and other components with best practice. So where to from here? So there were focuses that were identified and work has already begun in this space. So one being the development of an online learning package that would be added to our education portal, that would be mandatory for all ED and CCU staff to complete annually. Also, the department has worked on slides that can be added into our basic life support package that is organisational wide and required for all all GV health staff to complete annually. So we also have that in place. Might be considering nurse champions and laryngectomies. However, with shift work and rare presentations, we might go 12 months without seeing a laryngectomy. This may mean limited opportunities for a nurse to feel proficient and confident in all aspects of laryngectomy care. Further resources are required. So as you can see on the top left picture, creating laryngectomy kits, which will include all the equipment that would be required in an emergency airway event, as all appropriate resources that would be applicable to staff, and this would be provided to the ED department, CCU, and one within the speech pathology department. And then further data collection regarding changes in confidence and knowledge of medical and nursing staff would be beneficial to complete as well. So thank you so much again for viewing my presentation, and I look forward to answering any questions you may have. Thank you.
Thanks, Katrina, and thanks, Liz. Both very interesting projects and really interesting outcomes. As Katrina mentioned, really keen to have any questions that people might want to raise about either of those projects. Katrina will actually be joining us shortly on our panel to answer your questions. So please, as I mentioned before, use that Q&A box to put any questions forward that you might have. Our next speaker for today is, of course, known to all of you, Dr. Javier Torres, who, of course, is the clinical director, clinical director of medical oncology at GV Health, and, of course, one of our clinical directors for Hume for the Goulburn region. Javier, of course, has a very strong interest in research and education, as well as delivering services, as you can see there in his bio across a wide range of areas, and like Craig, has been very instrumental in developing oncology services across the Goulburn region and more broadly in the Hume region. Javier will be talking to us today on the topic of resilience from a regional cancer service in the middle of the pandemic. So welcome, Javier, and I'll hand over to you.
Thank you very much, Michael. Let me just to make sure that I share the right one and not the wrong one. There you go. I think it should be okay now.
Yes, great. Thanks, Javier.
Thank you very much. So the title sounds a little bit like grim, but look, it's basically about a few good things that still happen as Dr. Underhill basically have explored the options of, and actually was the leader regarding the telehealth and the RTN and the successful grant with the Department of Health and Human Services as well. So look, this is going to be a little bit about what happened in the last year. And basically, we just highlighted one of the projects that I wanted just to mention that we make it happen, and just to touch a little bit about other things. If we started, so we come back to just not long ago in August, Shepparton was on the news all the time, but basically because of the outbreak. And we know that about a third or even up to half of the population really was in quarantine. However, we noticed twice in Shepparton, all the population, diverse members from all the different, or even from locals, no locals, people who has been around and working in Shepparton, they really were going to support all these situations. So they were you saw in the news, testing, people regarding making food, supplying food for people who cannot afford it. So amazing people that I could really, I really was very impressed how the community was together and really supporting each other during this difficult time. And I think was the reason with the support from the health services and the leaders from particular GB Health to get through, and we are perhaps in a better position now, or we are in a better position now. And then we as a unit, we needed to respond to that one as well, because if the community was doing all this, and you see all the people supporting each other, we need to do it as well. So we came together as well as a team, this great team actually that we have here in Shepparton, from Allied Health, from the people from food services, the people from security, doctors, nurses, clinical trials, so pharmacists, everyone really working together to support, and we managed to really fulfill our duties. We know that a lot of the staff was in isolation. We created and established very rapid response to telehealth. And we are able to see new patients. We did not need to postpone any curative intent treatment patients because of the pandemic. So it was very nice to see that despite of all those issues and with the support from the hospital, we were able to still fulfill our services for the community. And then we say, look, we were thinking about this project that has been quite on the news and quite in the literature long time ago. And in fact, we got very close to us here, Dr. Christopher Steer, who is one of the leaders of this geriatric oncology in Albury. We were looking about implement this project, but was very difficult in the middle of the pandemic and what options we can do. So there is evidence that elderly patients, we could say more than 70 years old for this discussion. They are the majority of the patients who presented with malignancy. We know that we are living longer, and 1 out of 2 males or 1 out of 3 females, we are going to be diagnosed with some sort of cancer by the age of 85. And we know that the population more affected is regarding the geriatric population, as we can see in this chart, regardless of the type of cancer, always is going to be more commonly on patients above 65 years old. And also we know that the mortality is higher in them, and the complications and all of the issues, including delivering of treatment. So geriatric oncology is something that has already evidence from the last 20 years, I would say. In fact, we got very good data from for research done in Victoria that was presented on ASCO a couple of years ago, showing the evidence about decreasing the rate of hospitalization, increasing the rates of treatment that can be delivered to those patients, decreasing falls, decreasing complications. You can argue still some questions regarding survival benefit, but regardless, all of there is very high evidence that definitely that will prevent these patients to get complicated, and number 2, improve the outcome of the patients. So the project was also discussed, as I say, with some members of the who are interested in geriatric oncology, and basically elderly population got many reasons why they got more complications when they got systemic treatment, including chemotherapy, immunotherapy, or targeted therapy. So that was something that has been researched that is called the Comprehensive Geriatric Assessment, or CGA, in which they assess all these 7 parameters during the interview. And based on this assessment, they can create a plan for which the general practitioner and the medical oncologist or hematologist can tailor some of the treatment or adjust doses according to the frailty scores of the outcome of this assessment. So the first step was basically to check for this literature. And we can see even data just now. This is just now from November 2021, in which more data coming up. This is from United States. This is looking not to the big hospital, but looking about just services in the community. About 40 of those services, there were people randomized to have this assessment of GCA and then deliver the treatment, or do the standard, or we shouldn't say the standard of care, or do what we're doing at the moment, which is just the patient is seen and we start treatment as we do for the youngest, that's 70 years old. So the outcome of this study basically was that definitely the outcome is going to be improved if the patient got the geriatrics assessment and the tailored treatment as per the outcome of the assessment. And therefore, these patients will have less falls, less likelihood to go hospital, less likelihood to fill up our emergency departments, and the outcome is better. So, and then I start to review that, and even if we see, even if our pets got geriatrics oncology guidelines, I think definitely we are really behind. But this is not in the regional, also in the metro. So I think we needed to move forward with this. We needed to make it happen to somehow. So we knocked the doors from Hume. We got Beck and Sayan here, who really support us in this project. We knocked doors from the geriatrics team here in Gorbon Valley Health, but however, given the pandemic, of course, and they were no capacity at this stage to be involved in the project. But we got the access now to telehealth and be able to access other metro services in which we can come together, and we as oncology team, Hume Riggs, nursing team, some consumers as well, we find about what will be the best and realistic way to come with this project to happen. So we were also successful for a grant application through, once again, the Department of Health and Human Services. And we managed to establish a good relationship with the St. Vincent's Hospital Geriatrics Unit via telehealth, with the expertise on geriatrics assessment, comprehensive assessment. And we able to establish a clinic for these patients that could happen in the future. And then was how we can screen these patients to narrow the number of patients that really will need or will benefit from those assessments. So the next step was to look about this screening tool. We call it the GA screening tool, which is well known. Actually, it's a French tool in which we can narrow the patient who got deficient on one of those domains. For example, mobility, issues with nutrition, issues with cognition, issues with weight, and most importantly, medication is one of the main things that I have noticed that has been very successful when we do this assessment. Review those medications that this patient may not need or will be against the well-being of this patient. So basically, we came to the plan that, look, if we do this assessment screen, we want to take some patients that will really benefit as per evidence base of this geriatrics assessment. So we basically take patients, new patients, starting treatment, more than 70 years old, who presented to medical oncology in Shepparton and Gorbon Valley Health. We apply the GA screening, and if they got less than 14, they are the patients that are referred to the comprehensive geriatrics assessment, which I mentioned will be done via telehealth with the St. Vincent's Hospital attention. The other patients, I shouldn't say once again standard treatment. I will say the other patient will follow what we're doing at the moment, which is just deliver the treatment as per our assessment in the short time that we have in our clinics and slots. But basically, that was the way that we can try to narrow this number of patients to be able to offer some service, at least from the beginning, when our capacity is going to work in the future. So as I say, so the patient came to the clinic, to the medical oncology clinic. Then the nurses from medical oncology is going to do the assessment, is going to do the screening tools regarding other things like cognition, like nutrition. And then we, the oncology consultant who is doing the clinic, are the one in charge to fill it up, the GA screening tool, which doesn't take too long, can be squeezed into the clinic of a new patient. If we have all the papers set up, and basically it's a score that we can do electronically as well, which is very simple to do, and we can get the outcome straight away if the patient would benefit of the geriatrics assessment. And then the patients who are who are the ones who are going to benefit of this assessment were referred to the St. Vincent's Hospital / Gorbon Valley Health Geriatrics Comprehensive Assessment, which is together with the service of St. Vincent's Hospital. And then the patient come together with a family member when we could, depending on all these restrictions as we hear this year. But always there's going to be our star coordinator, Cheryl, who has been exceptional in order to make sure that this project go through, because regarding the referrals, regarding the information, regarding to make sure that the patients come on time, what sort of information the geriatrician need to know before the assessment. So Cheryl have been very important in this process to make it this happen. And then the patient is seen in clinic together with Cheryl, the geriatrician, and they can explore all the questions and then can elaborate a treatment plan that is going to be sent to the medical oncology team, but also to the general practice. More in particular, I have noticed a lot of assessments regarding the medications that need to be adjusted, noted questions regarding, is this patient suitability for this type of treatment because maybe they could not tolerate it, or what sort of things we can do in order to this patient to tolerate the things. For example, some interventions regarding exercise physiologies, for which we got an amazing team here in Shepparton, and also with the support of the Hume with Beck, which started on this well before for the wellness and exercise program that we oncology, we keep supporting, because we see really the benefit, always positive comments about that. Nutrition, which as well, we got some support from the dietitian department, and also from our clinic here in-house in the oncology unit regarding psycho-oncology interventions, which can be delivered in here. And also, once again, the thing that I had really catch me out regarding is this medication that sometimes we don't have time to request or to check everything. There's an intervention that we need to change in there. I have noticed that, and that's very important. That something that most likely sometimes we miss, to be honest, and we continue with some sort of treatments. So basically, that's the main project. So it's something simple, but able to happen, and it's happening. We got some data in here. We can see regarding what happened in those 2 months that we have running the project. We don't have data from October yet, but basically about 94 new patients oncology, as expected, about half were more than 70 years, which were filtered in order to get this screening. The screening were 34 patients, and the patients who scored low or were the one that we need to refer were about 26 patients in that term. And from these 26 patients, all of them were suitable for a comprehensive geriatrics assessment. The referrals were done, which is one of the processes that I'm going to comment in a few seconds that we need to improve. And some patient, or not some, one patient declined it, and the other patient was already seen by geriatrics in Gorbon Valley Health. So some of the patients have already the assessment, and we can see those outcomes. And some of the patients did not require it because they were not diagnosed with malignancy and they were discharged in the community. So just to summarize, some feedback about this project in the last 2 months, 2.5, 3 months. I think we need to improve with this streamlined referral. especially because we are working with St. Vincent's Hospital, that is something that we need to improve regarding how we do. And we have already approached the geriatrician department here, which I call it department, but it's a thing. We are in the process to get a second geriatrician, or is already working with us, but given limitations for physicians, he is going to be working currently as a physician and doesn't have enough time right now to participate in the project, as for my discussion with the CMO just a couple of days ago. But this is something that once the things start to settle down and things, we can collaborate with the local geriatrician and get some expertise, because expertise needed as well about this comprehensive assessment from the geriatrics team. We wanted to scores to involve the hematology patients as well, not only from oncology, also to involve our outreach clinics to participate on this screening, and then this patient will benefit from this assessment as well. The most important, as we all know, is going to be the sustainability. And I think it's possible, because I think the Medicare item number for this assessment got a good value, in which hopefully that could be able to be continued. The problem, once again, is going to be the coordinator of this, the nurse/coordinator of this program, how we can get this sustained in the future, because definitely it's going to be very essential to continue with this process. Once again, the discussion about in-house geriatrician, that hopefully is going to happen, and hopefully is going to be more recruitment in the future. Our hospital is growing in all the areas, and maybe the way that I will see this in the future as well is for the coordinator not only to help with the referrals, with the communication between GPs, practice and hospital and doctors, but also maybe to do these essential initial tools like cognition tools, like up and go tool that can be done very simple as before. So when they go through the screening, they got some safe time for the geriatrics clinic, and then could focus more in other aspects of this assessment. So in other words, we are very happy that at least we started in the middle of the pandemic. It's happening. I believe there is a very important process. There is a lot of evidence base. We are behind on geriatrics oncology, not only regional, but also metro. But I think we are very proud that we, with the support also for and discussions also, with, as I say, with Dr. Christopher Steele as well, who I discussed this project as well before, and he's done an even bigger project now as part of the Revitalize project for the RTN in the Gorgon Valley, in the border oncology area. We can collaborate and let's see something that we can even extrapolate for other services in Victoria. So I think that was something short, but I'm very punchy about something that we have done just in the last few months. Thank you.
Thanks, Javier, and that's for a very interesting presentation. We're now going to move into our Q&A session. So we've got three panelists tonight, Javier, Craig Underhill, and also, as I mentioned, Katrina Rogosh is also on the panel. Our discussion today is going to be facilitated by Tanya Holland. As you probably all are aware, Tanya is one of our project managers in HumeRx, and she'll just be moderating the questions that come through. I notice there are a few questions already in the Q&A, so I might hand over to the panel to start working through those questions.
Excellent. Thank you, Michael, and thanks for joining and turning on your videos, panelists. I've just got a few questions that have come in, and I think that we'll direct the first question to Craig. Craig, thanks for your presentation. This question goes to the clinical trials, and it says, can you identify the type of clinical trial which can't be undertaken by telehealth, and what impact does this have for our regional patients?
Thanks, Tanya. Thanks for the question. I think that the phase 1 study between Alfred and Hobart and the health services research program that we're rolling out really show that anything can be done via telehealth. So it's really just conducting a trial and using digital health it can be deeply embedded in the trial and all components doing it, or just parts of the trial can be done using telehealth. So teletrials maybe is a bad name, I'm not sure, and maybe the digital trials, maybe does that better reflect what we're doing, or decentralized clinical trials, which is being used in Canada, maybe that's an appropriate term as well. So there's different terminology in play. It's really just utilizing telehealth where we can in the conduct of a trial. So I think the implications, the second part of the question is that, especially with the national program about to start early next year, with some incentive payments or capacity coming to across the country, there's going to be an opportunity for more sites to be doing trials.
Good, thank you. I guess it's getting your head around how to use that digital technology. And it mightn't be for everything, but it might just be for a small portion of that clinical trial process.
Yeah, absolutely. So in the most clinical trials protocol, there's a table of procedures, and traditionally, they've all been done face-to-face, but with pandemics shown us that you don't necessarily need to do that. You can do consultation over using telehealth. You can dispense a drug at a remote site. Traditionally, we've done things like got people back day 7 of the trial for a physical exam. And what's that all about? It's just really touching base with them to see that they're okay. So we can now do that by telehealth. Or if we need a physical exam, I think someone put up a question that disappeared, can people come into their health service to do telehealth? And that's a great model. We can have a patient in a small town who maybe is not savvy with the technology, wants some support. They can go into the GP surgery, sit with the nurse or the GP, do a consultation. They can do the exam for us. We can record the information at the primary site, purposes of the trial. So it's really opened up the field.
Perfect. We've just had another question come in around telehealth, but I'm going to pause on that and just cross over to Katrina, because we've had a question come in that looks like it's for you. Yep, you've mentioned that you've required future data to determine ongoing staff knowledge and their comfort with managing laryngectomy patients. How in the future would you mitigate the low survey response rate that you initially received, and was there an identified issue?
Yes, we have started to collect some further data already. I think the main thing is ED staff availability. So we have been conducting our questionnaires at the morning huddle between each shift in the AM and PM to try and target nurses at a time when they are not, doctors when they're not as busy. We have also started to send out electronic versions of the survey, but that is probably going to be a little bit more challenging because ED and nurses and medical staff don't always have regular access to their emails. We've sent it to the nurse unit managers and senior medical professionals to disseminate it for us, and we're also speaking with the clinical nursing educators as well about supporting us in trying to get further data on this.
That's great, thank you. I wish you all the luck with that.
Thanks.
Next question, I'll transfer over to Javier. Javier, there's a question here that says, can geri-oncology, this service, be extended to people under the age of 70, which was your criteria, who have significant impact due to existing comorbidities?
Thank you, Tanya. I think that's the question. So the question, can you hear me?
Yep, I can hear you, thanks.
Good, thank you. So I would say that's the question that still we have some time regarding what is the elderly population. This is 65, 70, 75. I think still there is a little bit of intervention there. I think most of the kind of age that we are using is about 70 years. I would say definitely something that once the capacity has increased and is reached, definitely it's something that we can explore. Maybe we don't call it geriatric oncology, but we call it, yeah, some oncology with people with more than whatever comorbidities or this type of people, different name, but kind of the same process, seen by a physician who have the time to have the 40 minutes assessment or so, on top of the oncology assessment, and then come and approach there. At the moment, we are focusing, of course, on this population, basically because of we need to narrow those slots and try to get the patient who will benefit the most.
Great, thank you. I am going to leave it there just in the interest of time. I've got loads of questions that I could answer, and I do apologise to Kathleen that we won't be able to get to your question. Michael, I'll hand back to you.
Thanks, Tanya, and thanks, panel, for answering those questions, and indeed for all your presentations today. It's been very good. So we're just moving now to closing today's forum. So again, just reiterating my thanks to everybody who presented today, and certainly for those people who also sent in questions. I am going to hand over for our closing comments to our new program director, who's just been appointed, Annie Wilson. Annie Williams. So Annie will just give you a bit of a overview of what it looks like for the future of Humerix. As you've heard today, there's been quite a few challenges, not just over the last 12 months, but over the last couple of years with COVID and other things that have been challenging. Annie mentions newly appointed into the role, and very interested to hear her final comments regarding where we're heading with Humerix. Just before I do that, I do want to just pay a quick note of thanks to Cyan Wright, who did fill in for a while as program manager. Thank you to her, and thank you to Sophie Scott, of course, who was a previous program director prior to Annie taking on the role. So thank you for that, and I will now hand over to Annie. Thanks, Annie.
Thank you, Michael, and thank you all. Look, in finalising tonight's presentation, I'd really like to celebrate and congratulate the Humerix team, the medical and clinical needs, and all the Hume region staff, and together with the resources of the Victorian Cancer Services Network, who've contributed to some fabulous outcomes for patients, carers, and our consumers in our communities. A special mention, of course, to our presenters for this evening, who've provided their time and efforts to for our forum. So their contributions are very well valued. So thank you very much. These collaborative efforts have supported the programs which are designed to achieve equity and access of quality health and cancer-specific services across our networks and our areas. And Humerix has contributed this by supporting investment in current and future programs, projects and services to continue to improve cancer services for members of our wider communities. I would also like to thank the members of the Humerix team who've worked tirelessly to finalise and coordinate this forum. To support planning for future events, we'll be distributing an evaluation survey to all registrants for the forum. And we would be delighted to hear how we can continue to deliver forums to our wider networks that are innovative, educational and inspirational, or with patient experience and outcomes as a key focus. I'm also pleased to announce that Humerix will be launching tomorrow an electronic version of our annual report, and the details of how to access this will be included with your survey, so keep an eye on your emails, please. As always, our team is always here to assist, and I'm learning that from my 2 weeks working with them, so please feel free if you'd like to access the Humerix annual report in a different way, or if you have any feedback, please feel free to be in touch directly or via our Humerix email, which is humerixinfo, or one word, @gvhealth.org.au. And thank you so much for your time and expertise, and look forward to meeting more of you personally. So thank you. And thank you, Michael, for your efforts.